Welcome to this 2020 PCR e-course on durability of transcatheter aortic valves. My name is Lars Sondergaard. I'm a cardiologist working in Copenhagen, Denmark. I'm here with Hendrik Treede, a cardiac surgeon from Bonn in Germany, and Corrado Tamburino, a cardiologist from Catania in Italy. So we have all seen that TAVI has been expanded to patients at low surgical risk, and we also expect in the near future that it's going to include patients at a younger age and with longer life expectancy. So Corrado, moving to patients with longer life expectancy, what is the most important question for you?
So I think that the most important question is to see if valve durability is as long as we would like it should be in order to move to younger patient, asymptomatic patient, bicuspid valve, etc., etc. So we need some data on very long-term durability, and to understand also which is the best valve for each patient, having different technology and different platform that may help us in the correct choice, patient by patient.
Do you agree, Hendrik, is durability the most important question in these patients with longer life expectancy?
Well, I would say yes. And in order to have the best results there, we should have a clear look in these younger patients or lower risk patients who have a longer life expectancy on the anatomy of everything. So we have to only pick patients who are very good targets for TAVR. Then if we pick a TAVR valve, we have to see that we might face a situation in the future that they need a second valve. So if we pick the first one, we have to have the second one in mind. And then also, we should somehow know the average freedom from structural valve degeneration in the various valve types we implant. So if we have a valve that we don't have any long-term data on, it's maybe not the best valve to pick for a young patient at a low risk.
So we're talking about different endpoints here for these patients. It's not only about short-term endpoint, but it's more about lifetime management of these patients. And of course, durability is very important. In the past, we didn't have any clear definition of durability. And of course, if we want to compare transcatheter and surgical bioprosthetic valves and also different transcatheter valves, we need to have consensus for this. In 2007, we saw a consensus report about durability, defining it as valve dysfunction and valve failure. And from the low-risk trials and also from the market, we know the two dominant valves is SAPIEN platform. It's a balloon expandable valve with internal position of the leaflets, and the Evolut or CoreValve platform, which is a self-expanding technology with a supraannular position of the leaflets. And we got now actually at least medium-term durability data. These are from the Notion trial, 6 years comparing transcatheter valve with the CoreValve platform with the surgical valves, and we can see structural deterioration was very rare in the TAVI cohort. Only 1% of the patient met that criteria 6 years compared to 12% in the surgical cohort. We have also 5 years data from the PARTNER 2 trial using the SAPIEN, the balloon expandable valve. And here you see an opposite pattern. So only 3% in the surgical cohort met this structural deterioration at 5 years compared to 8% in the TAVI cohort. So, Corrado, is that sufficient data for us showing that it's a similar rate between transcatheter and surgical bioprosthetic valves?
Thank you. So the numbers are small numbers again, still. So we need to have, I think, larger numbers, even out from a randomized study, but also evidence-based medicine-derived data. But what is important is to know that normally in the surgical series, we observed that the peak of structural valve deterioration occurs at 8 years. So I think that it is too early to drive some conclusion, definite conclusion, and to wait for few more years in order to have more data that could be more reliable data. And it is important and is intuitive that the in valvular prosthesis have a higher gradient and faster deterioration as compared with supravalvular with less turbulence flow supravalvular position valves. So I think that is too early, also, although is very, very encouraging because we know that at least we have the deterioration similar or even less worse or better than surgical valves. And we know that failure is the same. And failure means revalving. And so this is the same.
So Hendrik, 5 or 6 years, is that sufficient follow-up to talk about valve deterioration in these? And what is your experience from the surgical literature in surgical biprosthetic aortic valves? How long follow-up do we need before we can conclude that the valve have a decent durability?
That's a very good question, Lars. Well, we know from surgical experience that structural valve deterioration starts at 5 years. This is what we know from other studies other than the two you presented here. If you look at the data you presented, it's a bit strange that we see completely different numbers for the surgery group within the two trials. It's 3 times as much SVD in the core valve study than compared to the partner 3 study. So that's a colorful picture that I don't really understand at this time point. From surgical experience, we know that it takes at least 5 years before a valve deteriorates in a significant number, and the differences are becoming quite accountable at about 10 years. So I agree with what Corrado said. We have to wait at least 8 years, maybe 10 years, to really get the true picture. But it's good that we do all these exams now, that we look for echo, and something also the surgical community learned from cardiologists, that we have to look for echo data and not only for freedom from the operation.
So that's also the good thing about these low-risk trials. It's going to follow the patient for at least 10 years. So we're going to have long-term durability data to see whether these actually can match the surgical valves. So looking at the hemodynamic outcomes, again, from the 2 low-risk trials, if you look here on the left-hand side, you can see that if you use the SAPIEN platform, the balloon expandable, you actually get a smaller opening area than you can get with the surgical valve, and similar, you also get a higher mean gradient. On the other hand, if you use the core valve Evolut platform, self-expanding technology, you get a larger opening area and a smaller gradient than you do with the surgical valves. You can say these, of course, are 2 different studies with different patient cohorts, but if you go to the next slide, we can look at the choice trial. It was not a very large trial, but again, about 120 patients in each arm randomized to the SAPIEN platform and the core valve platform, and you can see consistently out to 5 years, you have almost a double gradient with the balloon expandable valve compared to the self-expanding valve. And again, going back to the 2 low-risk trials, we also saw that these smaller opening area and higher gradient also transformed into a higher proportion of the patient who have severe patient prosthesis mismatch with the SAPIEN platform. It was around 8% of the patient, and the same magnitude as for the surgical valve, whereas you with the self-expanding technology saw a much lower rate and maybe most important, a lower rate than with the surgical valves. And again, looking here at the choice data at 5 years, randomizing patients between the SAPIEN and the core valve platform, there's a higher mortality rate. It's not significant, p-value 0.12, but it's a trend to have a higher mortality rate with a balloon expandable valve, about 50% higher. So, Hendrik, what do you see? Is that important what we see here? Is it too early signal to conclude that patient who receive a transcatheter aortic valve with a smaller area and a higher gradient is going to have a worse long-term outcome?
Well, I think this is very important data, and it shows definitely how important these hemodynamics are. So we should always make sure that no patients leave the hybrid or the surgical OR with a high gradient and a patient prosthesis mismatch, because the long-term outcome of it is bad and much worse than for patients who don't have it. I'm not sure if you can really make at this time point the comparison between self-expanding and balloon expanding valve when it comes to mortality over long term. I think that's too early to say. The choice trial maybe gives a hint here, but I would not, dive too deep into this at this very moment, because there's not really a randomized comparative trial between the 2 valve types at this time point. that undergoes the same conditions than the larger trials went through that you showed before. But yeah, I can just emphasize that hemodynamics are very important, and both surgeons and cardiologists should look for it when picking the valve they implant.
And you, Corrado, what is your take on this hemodynamics effect on the clinical outcome for the patients?
It's something that we know for many years, that the patient prosthesis mismatch has a negative impact on survival of the patient. So when we make a choice concerning on the prosthesis we want to implant, we need and we must do a technical choice according to the predicted final gradient. So I think that when we face with the small annulus, we need to go for a supravalvular position. When we go for larger annulus, we can go with both valves. But I think that hemodynamics is a priority when we look for a TAVR regarding the patient safety and survival.
So, Hendrik, we have during the last 5 to 10 years routinely used CT scan before transcatheter aortic valve implantation to measure the annulus. And we have also seen that in many institutions it's also used to patient who's going for surgery. So let's say we have a patient in front of us with a small aortic annulus, and we consider this patient to be at high risk for severe patient prosthesis mismatch with suboptimal hemodynamics and maybe impaired long-term outcome. Is there a role for surgery in these patients these days?
Well, I personally would say yes. There have been, discussions along the last past years saying that when you have a patient with a small annulus, you should definitely only consider TAVR. I don't go this road because I think there are nice surgical techniques that help out in the situation, and we routinely do, at least in the experienced centers, root enlargements for surgery, and always make sure that the patient ends up with the largest possible valve size. And then we have good results too. But it's, of course, a more difficult surgery compared to a routine AVR. But I completely agree with what Corrado said before. If we have a small annulus and you want to do a TAVR, then you have to pick a valve with a supraannular valve position. You should not go for a valve that is intraannular and can only end up with a higher gradient and small opening area afterwards, because there's technically no other possibility. So this is these patients we should always consider TAVRs in supraannular valve position.
So, Corrado, for you, again, to try to optimize the hemodynamics, what is your consideration, not only for the choice of the valve, but also taking, again, the lifetime management into the consideration of these patients?
Yeah, it is important because if you have a short life expectancy, you can put any valve you want. But if you move to younger patients, to low risk patients, and to patients with other comorbidities, but in young age, it is very, very important to predict a long-term expectation to the patient. So the hemodynamic, again, is very important. Surgery may play a role and has an important role, but unfortunately, as Hendrik said, and I agree with him, to perform a good surgery is more complex than to perform a standard procedure. So we have to face with our internal performance given by surgeons or by interventionists in making the proper and the appropriate choice. But I think that a small annulus and young patient should go, if they are low risk, to surgery.
So I think this was a very useful discussion here, and hear your take on these data here. So again, if I should summarize, we have seen that transcatheter aortic valve implantation has expanded not only from high risk to low risk patients, but also to patients at a younger age. And I think in the very near future, we're going to see patients with much longer life expectancies going to receive these valves. And of course, durability is a very important measure here. We have data now out to 5 and 6 years, which is quite encouraging, showing it's not inferior to surgical valve. But again, remember, even a poor surgical valve will make it out to 5 years. So we need longer follow-up, at least 10 years. We talked about how to optimize the outcome, particularly in patients at risk for severe patient prosthesis mismatch, using valves with a large opening area and a better hemodynamic outcome. So with this, I want to thank you, Corrado and Hendrik, for joining me here. And I wish you all a continued good PCR eCourse 2020. Thank you.
Thank you. Bye-bye.
Thanks very much.